Go ahead.
Okay, great. Well, it's my pleasure to introduce Michael and Anna. They've done some really lovely work on this project. We all are in healthcare are increasingly noticing the importance of health equity as being sort of central to our mission. And certainly the Betty Moore Heart Center is focused on that as an emerging metric. And we know from national data that there are existing inequities within cardiac critical care and more broadly with pediatric cardiology. But we don't really know what our outcomes are at LPCH. And so what they've undertaken is this project with existing databases as well as the EHR to sort of quantify what our outcomes are and what disparities, if any, exist. And this project, we hope, will be, actually, I just came from a meeting where we talked about creating a broader health equity dashboard. So there's already a lot of enthusiasm about continuing this work, and that this will be both a impetus for improvement projects moving forward, as well as a quality control metric for all of us. So I'll turn it over to them. Thank you.
Awesome. So thank you so much, Rebecca. Yeah, Anna and I today are here to talk to you guys about the health equity work that we've tried to do with SURF. So, all right. So as I said, Anna and I worked together on this project, and people that we'd like to mention are Dr. Kameny, Dr. Kipps, and McCall. They really were instrumental to helping us kind of work through this project. So thank you so much to them. All right, so starting off, on the left side of your screen, right maybe for you guys, sorry, left for me, you can see a bunch of articles that kind of talk about this health equity issue, but at a national level. Basically what we're seeing is that people of demographic backgrounds that are marginalized tend to have disparate outcomes. And so what we want to do is then take that knowledge and apply it at an intra-hospital lens. So that's kind of that first project goal that we're looking at. Secondly, what we want to do is to ensure accurate and standardized visualization and representation of that data of health equity. And then thirdly, what we want to do is create a method for displaying that health equity to see those disparities, whether or not they exist, to measure performance and the impact of any interventions that might take place. So the process that we went to accomplish this was first to work with our key stakeholders and our project sponsors to outline issues and brainstorm health equity metrics that we'd want to track. From there, what we did was we looked to the literature, we looked to what experts were saying in this, like how exactly are we going to track this, how are we going to analyze this? And then from there, what we did was we took the data that we had and we put it into Arbor metrics and compared it to national trends. So what's happening at a national level and how exactly does Stanford relate to that? Then from there, we took our data and did more so of an internal analysis, built our dashboard, and saw what exactly was going on within our own hospital. Importantly, we used the LPCH's surgical data set, and our data ranges from 2017 to 2022. And then from there, what we did was we said, okay, how exactly can our research, our project be used in the future, and how best can we aid any efforts that are going to be taken? One of the key and most important factors when you're dealing in this realm of health equity is standardizing your data. But second only to making sure that you standardize your data is finding a tool that you can use to make sure that you have a good and valid standardization tool. So kind of a novel method we took to doing this was to use cardiopulmonary bypass time to evaluate our standardization tools. And so cardiopulmonary bypass time tends to be one of those things that is a really good capture of procedural complexity. And so typically what you would do is you would look at this procedural complexity and within stat category. But as you can see on the graph on your left, my right, is within stat category, you see a really high variation in cardiopulmonary bypass time, which in some cases can be really bad because cardiopulmonary bypass time, one, can only happen for so long. Otherwise, the patient may face mortality. And two, you want to have very small variation in that because ensuring that equity within cardiopulmonary bypass time is a really good way to make sure you're producing equitable outcomes. So what we did was we said, okay, stat category may not be the best way to standardize our data. What we probably want to do instead is to look at procedure, which is the graph on the other side, basically showing that like there's a lot less variation in terms of the cardiopulmonary bypass time if we identify individual surgery types. So what we did was we said, okay, this is going to be a really good way to try and capture the effects of procedural complexity, pre-existing health conditions, among other things, so that we really are only capturing, say, those demographic characteristics that we want to track. And I'll pass it on to Anna to get a little more into that.
Yeah, so once we decided we were going to look at procedure as a way to standardize, we wanted to make sure that within each of those groups, that complexity was relatively similar. So we had analyzed CPB time across different demographic factors, including insurance, ethnicity, and the Gauss Deprivation Index, a score given for socioeconomic status based on a patient's zip code. From there, we saw that CPB time was relatively standard across the groups, giving us confidence that within each of these groups, there was similar complexities in the surgery, and that our final dashboard would be focused more on the demographic factors and not these other complexities that may come within the groups. So from there, we developed a dashboard that can be used for the hospital that measures 3 key metrics. The first metric is a patient's post-operative length of stay, so after their procedure until their discharge. Here, you can see on this side closest to me, post-operative length of stay over time, as well as the general distribution. This is important because it represents incurred costs for both the patients and the system, as well as represents complications that may occur. We also looked at the average 30-day readmission rate, and working with our project sponsors and in the previous literature, 30-day readmission rate has been noted as a good way to capture unplanned readmissions within that window, which is really important. It has like what could be considered some of the biggest health equity concerns, as this could represent a patient not fully understanding their discharge materials due to it not being in their language, their primary language, or not being culturally competent enough, or not having access to good healthcare professionals that can help them through issues they find at home. So this really represents a lot of work the hospital could do. And then finally, we looked at database discharge mortality, the percentage of patients that passed away within the hospital, which was our most extreme marker. And then to note, this dashboard here focuses on unifocalization PA reconstruction with an ethnicity analysis, as that's one of Stanford's key procedures. However, we also developed multiple different dashboards, so focused on different demographic groups, as well as these different metrics and different ways to analyze them, such as looking at medians or averages, so that any provider who wanted to use this tool would be able to really focus it in on whatever their main target area was. It's also worth noting that throughout this process, we worked with a few other institutions who were doing similar work, as Rebecca noted previously, and their biggest concern was that they did not think standardizing by our procedure groups would be relevant for their institutions. So in our dashboard, we built in the feature of being able to standardize by stat category as well. Despite the fact that we agreed this wasn't best for Stanford, we figured it was an easy add and good to have that modality just in case we wanted to apply it to other institutions. So with that, this is the first phase of many for this project. Some of our key next steps are we want to continue the dashboard development and do further statistical analysis, as well as unionize with the hospital-acquired complications database. This was our 4th metric we wanted to look at, and we're not able to in our time frame. So it's our biggest next step, as well as considering metrics that can be measured for non-surgical appointments, as that does represent a bulk of Stanford's population base and also may show different disparate outcomes. And then continue to work with other external hospital systems to see how this could be adopted or used with their methods. Hopefully within the hospital, this will allow, once it's fully developed, will allow providers to identify disparities that exist within care and brainstorm potential solutions, but then also measure the impact of those solutions to see if the gap is shrinking between these different groups. And then finally, also identifying new key data collection methods. For example, we wished that we had primary language or number of appointments rescheduled as metrics. However, those weren't represented in our data set, so identifying those for any future research. So with that, thank you so much, and we'll take any questions.
I wonder how would you standardize the stat category?
Like between stat categories, or we built.
How would they?
Yeah, that's kind of something that we didn't mention in here for time constraints, but something that we were considering was, as Michael said, this kind of novel approach of considering CPB time as a marker of complexity. So we talked with our project team about potentially breaking that into quantiles and using that as a standardization method, either within the stat category or as its own. We weren't able to do it within our 10 weeks, but we considered that as a way that it could be adapted in the future that may be a better marker of complexity and could be used by other places.
And I saw all the mini dashboards you put out. That's actually something we would do as well. Just put out all the different options and let the stakeholders choose what are good metric or whatever visualization makes the most sense to them. Wonder if they actually take one of the mini dashboard.
To be honest, we still haven't had our final meeting with our project team, and so we have to continue working through at least visualization on that side. But based on essentially whatever metrics they want, it can be, as you probably know, modified so easily to represent that, which is like why Tableau is amazing.
Yeah, so as the medical director for quality and outcomes for the Heart Center, working with Dr. Kameny, one of our core goals really is to always have situational awareness about potential disparities in outcomes based on ethnicity and race. And so this dashboard, I can kind of project that will be a part of our routine review and screening during what is considered our Heart Center Quality and Performance Improvement Committee. This is a committee that I chair, and this is something that we are desperate to have integrated into our workflow, is to have a routine screen and a routine review about these particular metrics. And so, very soon, I think it'll be a part of our kind of standard of operating procedure of how we do business here at Stanford in terms of our outcomes. And I think this will be an example for institutions, as you probably experienced. There's a lot of interest about that.
Thank you.
All right, let's take this.